it's a pleasure for us to have you to bring the most recent information or highlights about CTOS 2025 in terms of to show the advances and perspective in sarcoma research. Today, we are going to have four leader key opinion from South America and Europe. And it's a very pleasure for me to invite Bruna David. She's from Rio de Janeiro, is medical oncology, and she's going to talk regarding the subtype of the sarcoma of the year, that is the chondrosarcoma, and she's going to give to us the novelties. So thank you, Bruna, for sharing with us this very interesting and the last meeting of the year from Selma. Thank you, Bruna.
Hi, everyone. Good morning, good afternoon. Thank you for the kind introduction, Matias. I am Bruna from Brazil. I'm a medical oncologist and also a member of the CELNET Executive Committee. Sorry about my conditions today. I need to connect from my cell phone because I don't have a camera in the computer, but I hope you can hear me well. If not, just let me know. Next, please, Isabel. So my mission today is to talk about novelties in chondrosarcomas, the so-called sarcoma of the year at the CTOS meeting of 25. Next, please. These are my disclosures to this talk. Next. So just to give you some quotes about chondrosarcomas, I'm pretty sure that you all know about it, but just to remind you. It's a heterogeneous malignant bone tumor that produces cartilaginous matrix, and they correspond to around 20% of the primary bone tumors. The most common subtypes conventional chondrosarcoma, and it encompasses grade 1, 2, and 3. Non-conventional chondrosarcomas are rare, and we know that they are composed by clear cell, mesenchymal, and differentiated. Mesenchymal and then differentiated chondrosarcomas are more aggressive and have poor prognosis. So today here, I'm focused in conventional chondrosarcomas. So when you talk about treatment of this kind of tumors, we have the main approach for localized disease, the complete surgical resection. A resectable or metastatic disease have few effective systemic options. They are chemo and radio resistant, and they don't have targeted systemic therapy until this moment. Next. Just to give you some numbers, we have very poor prognosis with or without systemic treatment. For instance, when you have the advantage of chemotherapy, with doxorubicin alone, you have a median progression-free survival of around 2.5 months, and the combos with the fosfamide or cisplatin around 3.6 months. With TKIs, the scenario is more or less the same. So it remains for us until this moment a significant unmet medical need. But my talk today is just to question and to show you some data that question this statement, let's say. Next, please, Isabel. Next. Nowadays, we are discovering novel signaling pathways, particularly for those tumors that are refractory to chemotherapy. I'm presenting here some new discoveries, such as mutations in the isocitrate dehydrogenase gene, the so-called IDH, the hedgehog and the death receptor 5 pathways, and immunomodulation. Due to time constraint, I'll focus here today in the mutations in the IDH genes and the DR5 receptors. Just to give you a comment, you know that immunomodulation is interesting in this kind of tumors because they express PD-1 and PD-L1 receptors, but I'm not focused here today in this kind of pathway. Next, please, Isabel. So starting with the IDH mutations, basically, it's again a function of IDH enzymes. We know that the normal role of these enzymes is to convert isocitrate in alpha-ketoglutarate in the citric acid cycle. When you have these mutations in gain of function, these enzymes convert also the D2 hydroxyglutarate, the alpha ketoglutarate into hydroxyketoglutarate. And this compound interferes with the normal DNA and histone demethylation due to abnormal accumulation and leads to global hypermethylation. This leads also to tumor formation. So if you see in the figure, when you cut this pathway, you have the shrinkage of the tumor, the entire pathway in the tumor formation. Next, please. Due to this rationale, phase 1 trial encompassed different solid tumors, including chondrosarcomas, were designed a couple of years ago with ivosidenib, a drug that inhibits these hyperfunctionating enzymes. So what we saw, a substantial reduction of 2-hydroglutarate reduction in the serum levels, and a duration of a response very interesting of almost 4 years, with a median progression-free survival of 7.4 months. The toxicity profile was very well manageable, with just one treatment-related grade 3 hypophosphatemia. Due to this data, a phase 3 trial was designed, next please, Isabel, to compare the efficacy of ivosidenib versus placebo. The trial is called CONQUER, is a phase 3 trial randomizing chondrosarcoma patients with the conventional subtypes, grade 1, 2, and 3, with conformity IDH1 mutation, to receive ivosidenib 500 milligrams orally versus placebo. If there is progression in the placebo arm, the patients can cross over to the ivosidenib arm, and the primary endpoint is progression-free survival. The good news is that have this trial also recruiting here in Brazil. Next, please, Isabel. A couple of other compounds are being tested at the same class. Next, please. But we still have some open questions regarding this class of drugs. First of all, the optimal combination to enhance the efficacy of IDH inhibitors, since you know that you have other pathways, as I said before, and I'll show you later. And the real role of 2-hydroxyglutarate and hypermethylation in driving chondrosarcoma growing. Next, please. The next class is the DR5 agonist. We know them for a long time, but due to concerns about toxicity, we are not using them in our clinical practice. That's why, because we have this interaction with the DR5 agonists, with DR5 receptors, and they are correlated with the TNF-related apoptosis induced ligand, the so-called TRAIL. TRAIL is expressed in many different organs, especially in the liver, and due to this expression, previous compounds, let's say previous classes of these compounds, they were very toxic because they were also targeting different health organs. They triggers the formation of this death-inducing signal and activates multiple downstream caspases and degrade the key cellular components. It's really interesting because these compounds, they don't need to go to the entire pathway of tumor proliferation. They engage the apoptotic pathway and trigger cancer cell death. That's why they are very active in chondrosarcomas, because we know that they are chemo and radio resistance, for instance, due to their poor vascularization and in general low mitotic proliferation rate. Next, please, Isabel. Next. And we have more recently the development of Inbrix 109 for close friends, the ozekibart. And this is a third generation DR5 agonist optimized for cancer bias targeting while avoiding concomitant off-site toxicity. Next. So we had this phase 1 trial showing that the drug, first of all, was well tolerated with a very low rate of severe adverse events. And the single agent activity was very encouraging, with a median progression-free survival of 7.6 months. And it was regardless of IDH1 and IDH2 mutation status. And due to this data, very happy about this suspicion of efficacy, a phase 2 trial was developed. Next, please. The ConDragon study was a phase 2, randomizing 2-to-1 patients with conventional chondrosarcoma with no worries about IDH mutation status to receive ozekibart 3 milligrams per kilo IV every 3 weeks versus placebo. And here again, if a progression disease was detected in the placebo arm, the patient could cross over to the ozekibart arm. And the primary endpoint was progression-free survival per RECIST. Next, please. After a median follow-up of 10 months, we saw that ozekibart improved the progression-free survival, almost the double that you had in the placebo arm. And after 6 months, almost 50% of patients had no progressive disease. Next, please. And this benefit was consistent across key pre-specified subgroups, including IDH mutation status and tumor grade. Next, please. The most common adverse events were fatigue, constipation, and diarrhea, with a very low rate of grade 3 events. And here it's important to say that the mitigation program to reduce hepatotoxicity was implemented from the beginning with liver monitoring from the first cycle. So in this regard, hepatotoxicity was also very mild, with a very low rate of liver enzymes growth. Next, please. So just to summarize what we have until now, we have, and here I didn't put chemotherapy because usually we offer chemotherapy for the differentiated tumors. So talking about conventional chondrosarcomas, you try to use more, at this moment, TKIs. And nowadays we have the promising of ivosidenib and also ozekibart. So just to give you examples that you can promote histology-tailored trials with sometimes molecular-driven drugs. Next, please. So to conclude, it's very nice to talk about this team today, because it appears that there is more than one pathway that drives the development of chondrosarcomas, and maybe if you combine them, you can improve and even more the management of advanced disease. And it's very, very motivating for us. Since until a couple of years ago, we didn't have nothing very exciting about the disease. And again, every sarcoma talk usually says that conducting trials focused on a specific histology is possible, and more molecularly driven approaches are feasible, and they should be pursued, especially in the context of rare diseases. Next, please, Isabel. Next. I would like to thank you for your attention, and also to the sarcoma family that are growing more and more over the years. Thank you very much.
Thank you, Bruna, very much for your excellent presentation. You know that you can leave all the questions to after all the session we are going to discuss, but you can leave in the chat. So we appreciate very much your presentation, excellent. And let's go to the next speaker. That is Fernando. He's going to talk about the novelties in soft tissue sarcoma, including immunotherapy. Thank you, Fernando, for your presentation and your stay here.
Thank you, Matias, for the inviting. Thank you, everyone. Can you see my screen? Can you see the slides?
Yeah.
Okay. So I'm Fernando Campos, medical oncologist from Brazil. I was invited to talk on the novelties in soft tissue sarcomas, including immunotherapy. So in the interest of time, I've selected 4 trials that present new data, which has not been presented before in other meetings. So in the immunotherapy field, we'll talk about, I'll present the results on IMMUNOSARC-2, the cohort 7A, and the CONGRATS trial. And then we will talk about 2 novel approaches for soft tissue sarcoma with very promising results. Okay, so IMMUNOSARC-2 cohort 7A was presented by Dr. Martin Broto. This is a Spanish study, phase 1b trial combining epirubicin and ifosfamide plus nivolumab in the first-line setting of advanced undifferentiated pleomorphic sarcoma. This study, as you know, is evaluating 2 dose levels, a phase 1b trial, evaluating these 2 dose levels with epirubicin and ifosfamide in these doses, combined with nivolumab 360 milligram on day 3, each 21 days, or 240 milligrams in this level -1. After 6 cycles of this combination, patients will keep on nivolumab as a maintenance phase of the protocol. Main inclusion and exclusion criteria here are patients with confirmed UPS, anthracycline naive, ECOG 0 or 1, with measurable disease, and the main endpoint here is to determine the MTD and RP2D based on DLTs observed in the first 21-day cycle. And of course, the secondary objectives are exploring the safety profile, response rate, and the survivals. So for the UPS cohort, 16 patients were included, median age 56. Most patients had lesions in their limbs, and most of them presented metastatic disease. As we can see here, the results of this combination in this trial showed an overall response rate of the 16 evaluable patients with UPS, almost 70% of response rate including 1 complete response and more than 60% of patients presenting partial responses. The median PFS was around 10 months in this trial. So in the overall survival curves, we can see that after a median follow-up of 16 months, the median overall survival was not reached, and the median duration of response was 12 months, as we can see here. 67% of the patients were progression-free at 1 year. Looking at the adverse events, all patients were treated at level 0, and most adverse events were those that were already reported for this combination, anything new and not expected for these drugs. So Professor Broto and the authors concluded that the combination is feasible and manageable. The combination of epirubicin, ifosfamide, and nivolumab, the preliminary activity is highly encouraging. 50% of the patients had not progressed at the time of cutoff, and this combination induces prolonged responses, as we saw, and this deserves further development for UPS patients. Secondly, in the immunotherapy field, I selected this trial presented by Professor Italiano from Gustave Roussy. The CONGRATS trial is a randomized phase 2 study combining nivolumab with relatlimab in patients with tertiary lymphoid structures positive soft tissue sarcomas. This is a randomized proof of concept multicenter phase 2 trial. They included patients with more than 18 years with advanced or metastatic soft tissue sarcoma who presented tumors with mature tertiary lymphoid structures by central review. Patients had to have documented progressive disease and no more than 2 prior lines of systemic therapy. The patients were randomized, 63 patients were randomized for nivolumab plus relatlimab or nivolumab monotherapy. The rationale for this study is that, as it was previously shown by this group and others, patients with sarcomas presenting this TLS do seem to respond pretty well to immunotherapy, and they overexpress LAG3, which is associated with worse outcomes, and relatlimab is an inhibitor of LAG3. So this is the reason why they are investigating these combinations. Patients who were treated until disease progression or unacceptable toxicity. The primary endpoint is 6-month progression-free, and the secondary endpoints included overall response, progression-free survival, overall survival, and safety, among others. As we can see, the combination of nivolumab and relatlimab achieved a 6-month progression-free rate of 26% compared to 39% for the group receiving nivolumab monotherapy. There were 10% of partial responses in the group with the combination and 18% of partial responses in the group receiving nivolumab monotherapy. The median PFS for the combination was 3.7 months and 5.2 months for patients receiving nivolumab alone. The median overall survival 12 months in the combination arm and 29 months for patients with nivolumab monotherapy. Safety or nothing new in the safety profile of this trial. And in conclusion, this is the first randomized prospectively study validating the tertiary lymphoid structures as a predictive biomarker in sarcoma immunotherapy. The addition of the anti-LAG3 relatlimab did not improve efficacy over the nivolumab monotherapy, and both arms exceeded historical benchmarks, confirming the clinical value of TLS guided immunotherapy. So this is why I selected this trial, since before it we just have had retrospective data with this TLS for guide immunotherapy. Two novel approaches that were presented at CTOS. This is the first I want to share with you. The investigators evaluated a new antibody drug conjugate, which has this name here, abbreviated as MICVO, in patients with advanced sarcoma. The idea here is that this MICVO, the ADC, is a first-in-concept ADC targeting extradomain B of fibronectin, which is a non-cellular structural component within the tumor extracellular matrix. This protein or this complex is overexpressed in several solid tumors, including sarcomas, but it's not very well present in healthy adult tissues, which makes it an important target for ADCs. This is the part one dose escalation of this trial. They included all comers with no biomarker selection, histologically or cytologically confirmed solid tumors, locally advanced, with RECIST measurable diseases. And these were the patients who were the tumor types that were eligible for this trial, and they included sarcomas here, which is the focus they discussed at CTOS. The primary endpoint is safety and tolerability, MTD, and to determine the next dose for development. There are also evaluation of overall response and survival, among others endpoints. For the sarcoma group of patients included in the trial, they were a total of 11 participants. They were treated with different doses, median age 52 years. Two patients have received prior anti-cancer. The median number of prior anti-cancer therapy were 2. These were the main sarcoma types included. 36% of the patients presenting chordoma, but there are also 27 or 3 patients with leiomyosarcomas here. The median duration of treatment was 65 days. There are 3 among 7 stable disease in 7 months, and 2 patients presenting partial responses in the lasting more than 100 days. As you can see here, 1 chordoma patient presented a partial response. 1 patient with endometrial stromal sarcoma also presenting partial response here. 1 patient with epithelioid hemangioendothelioma, and 1 patient with leiomyosarcoma with tumor reduction in the diameter of the lesion, but not reaching RECIST response. So in this trial, 11 patients with advanced sarcoma were treated in this phase 1 trial of this new ADC. This was generally well tolerated, manageable safety profile, and MICVO, which is the ADC, demonstrated promising anti-tumor activity among multiple sarcoma histologies, including 2 partial responses. And there was also some translational research included in this analysis of this trial. But in the end, I would like to present briefly present this trial, evaluating the safety and the early efficacy of this multi-TED inhibitor in patients with advanced epithelioid hemangioendothelioma. This is a phase 1/2 study presented by Dr. Haddox from Harvard. The background here is that this hypopathway presented here is it talks with YAP and TAS, and when the hypo pathway is on, these kinases here upstream on the pathway, they phosphorylate YAP-TAS, which makes this complex to be degraded in the cytoplasm of the cell. When the hypo pathway is off, the complex YAP-TAS is translocated to the nucleus, where it binds to the proteins of this family TEDs, which drives transcription and then tumor progression. As we know, epithelioid hemangioendothelioma is a rare vascular sarcoma, which is characterized by TAS or YAP fusions. The main fusion here is this one involving CANTA1 in 90% of the cases. And in these cases, the TED binding domain of the TAS is preserved, which makes this an active pathway in these tumors. And there is this new selective multi-TED inhibitor, which disrupts TED-driven transcriptional activity downstream of this YAP-TAS. So what happens here is that this new inhibitor don't allow YAP-TAS to activate these proteins and then stop the tumor progression. In this trial, they evaluated the doses of this new inhibitor, and they included patients with epithelioid hemangioendothelioma, 12 patients with this disease. In the end, they evaluated 14 patients with epithelioid hemangioendothelioma, most of the patients presenting the most common fusion of the diseases, and most of the patients presenting metastatic disease to the liver. As we can see, very promising responses, some three patients presenting stable disease, and partial responses, and one patient here with this more pronunciated response. In the safety profile, the most concerns were related to fatigue, peripheral edema, and proteinuria, but all of them mostly grade 1 or 2. So this molecule, VT3989, is the first in-class TED inhibitor disrupting TED transcriptional activity. There is a favorable safety profile and demonstrating compelling efficacy in epithelioid hemangioendothelioma, with results supporting further exploration in these diseases. So this is what I've selected. Thank you.
Thank you. Thank you, Fernando. Thank you a lot for your excellent presentation.
Hi, everybody. I just connected, but in Miami it's very early, so I really enjoyed the talk from my car, and I'm looking forward to the discussion. Thanks for having me.
Thank you, Manuela. Thank you for VTR. Let's go to our last speaker, that is Dorian. And remember that you can put all your questions in the chat. So we are going to discuss after the Dorian presentation. So Dorian is an important surgeon of Mexico. He's going to talk about the retroperitoneal sarcoma news in CTOS 2025. Thank you, Dorian, to be here.
Thanks, Matthias. Hello, everyone. I present to share the key highlights from CTOS 2025 concerning retroperitoneal sarcomas. In general, this presentation synthesizes the most relevant updates spanning the clinical trials, translational science, quality improvement initiatives, and global collaborative efforts, and provide a structured academics overview capturing of the involving integrated evidence from STRAS2 and STRAS3. That is the mainly point in this presentation. CTOS demonstrate a clear acceleration in high-quality research dedicated to retroperitoneal sarcomas. Several clinical trials refine our understanding of the neoadjuvant therapy and immunotherapy combination. There is a registry now. Unfortunately, the world largest has become a cornerstone for the observational studies. The risk modeling and Beckman outcomes, discussion of quality of care, highlight failure, and the rescued and critical modifiable drivers and postoperative mortality, translational, and other points like Apollo 10 introduced like a full proteomic platform for sarcoma, very molecular resolution, not previously available for in this disease. Meanwhile, the AGCC sarcoma committee outlined progress toward the night editing station system, emphasize histology specific and dynamic predictions models. That it's a very interesting point because we try to transform this classification in a new model, a dynamic model that is possible to obtain new information for our patients. Despite the meaningful progress, retroperitoneal sarcoma remain exceptionally challenging. The rarity and biological heterogeneity slow the generation of high-quality evidence. Outcome varies substantially across the institution, often reflecting differences in surgical experience, perioperative care pathways, and access to specialized multidisciplinary teams. Consensus that operative terminology is still lacking. Complicated multicenter analysis as emerging treatment paradigms incorporating immunotherapy, radiotherapy, and molecular profiling. There is a present need for unit frameworks that integrate the clinical, pathological, and biological determination and prognostic. Many of the CTOS initiatives, such as consensus driven surgical definitions, that is other point very important. Trial designs incorporating immune signatures and registered based in risk stratification, where I mean present and addressing these gaps in general. Currently, the state of art, this is in the retroperitoneal sarcoma reflected ongoing efforts to clarify the role of systemic and local therapies. The CTOS remains the leading randomized investigation evaluating adjuvant chemotherapy in leiomyosarcoma and high-grade dedifferentiated liposarcoma. And the CTOS planning now to leverage mechanisms evidence suggests the synergy between the radiotherapy and immunotherapy in dedifferentiated liposarcoma, particularly in tumors exhibit specific immune signatures. Research provide real-world benchmarks for morbidity, recurrence, and failure to rescue, identify areas for improvement across the different centers, translational immune class analysis, and the studies such as Pembrolizumab highlight the role the tertiary lymph node structures in the predicting immunotherapy responses. Meanwhile, in other points, the Delphi project present the crucial steps toward the harmonized surgical terminology to support reproductive and multicenter research. The insights presented draw from the comprehensive evidence ecosystem, randomized and not randomized trials, scale observation datasets, multi-omic translations, pipelines, and international policy-driven initiatives. This multimodal integration reflected the richness contemporary sarcoma research. For example, the Apollo applies whole genomic sequencing, transcriptomic, proteomic, and phosphoproteomic to define biological subclass in sarcoma and identify potential therapeutic target, and at the same time qualify focus frameworks such as failure to rescue shift attention throughout the methodologies, including Delphi process and others. The updates in the CTOS2 continue to be the most important prospective effort exploring the role the adjuvant chemotherapy for leiomyosarcoma and high-grade dedifferentiated liposarcoma. And the investigators reported 155 enrolled patients with balanced baseline characteristics across the treatment arms. The primary endpoints remains reduction in the early metastatic failure, which is particularly relevant in these histologies. Some problems recurring the challenge remain unsurprising given the rarity of these tumors, but the trial is ongoing and the activity progresses. The protocol refining the included updates the disease-free survival definition and the enhanced clarify the alignment with other retroperitoneal sarcoma studies. And the other is the stress tree. A concept represented a significant paradigm shift by explicit incorporation in immunobiology into trial designs. In CTOS, the discussion emphasizing that the G1 and G2, the differentiated liposarcoma, although often neglect the clinical trial, represent a sizable and biological relevant subgroup. Evidence from the SARC-032 demonstrate improved the disease-free survival when the radiotherapy was combined with pembrolizumab in UPS and the differential liposarcoma, supporting mechanisms synergic. Current deliberations focus the most appropriate control arm because some people, whether surgery alone or the radiotherapy plus surgery, give it variability in international practice. Immunoclass signatures, particular Psych-E, with the high tertiary lymph node structures density, offer the opportunity to biological enriched trial populations. Stress has the potential to become the first immunoradiotherapy retroperitoneal sarcoma trial. This is very important for the investigation about this neoplasm. Another interest point is the RESAR continued involved as an essential global platform for observational research, which over 3,000 patients in now enable robust analysis of the morbidity, mortality, recurrence, and surgical complexity. Observed complication and mortality rates reflect the real world benchmarks with the specialized center research now support multiple analytic sub-studies, for example, floral for recurrence risk, surveillance intensity studies, and vascular reconstruction outcomes, improving the follow-up, completeness, and the governance process further reinforce the quality of the data sets. As CTOS 2025, it's made a clear reserve not only as a research engine, but also as an instrument for global quality improvement. And the other very important study derived for the RESAR is the failure to rescue study design is the one the most influential quality care, of care of the topics was failure for the failure to rescue traditional metrics for focus in the complication incidents, yet reflect a center's ability to detect to manage the complication before they late mortality. Among the 2,000 patients, is the patient for the RESART. 38 postoperative deaths were analyzed throughout the structural root cases frameworks. Major contributors included delays in physiological recognition, time to interview, gaps, sepsis the origins, and graft-related complications. And finally, the Apollo 10 marks major leap in sarcoma translational research by integrating the whole genome, sequencing, transcriptomics, and proteomics. These platforms promise to define sarcoma taxonomy and identify new therapeutics vulnerabilities, immunoclass, TILs analysis continue to refine the select immunotherapy approach. This is very important point for the new studies. On the classification sites, the AGCC and work groups reported progresses toward the 90th edition, focused the dynamic prediction models and histologies. And this is very, very important. And like a conclusion, overall, CTOS highlights an important evolution in how the field approach the retroperitoneal sarcoma. New trials are leveraging molecular and immune science registered and driving large-scale evidence generation and quality is the initiatives shift attention and the towards the modifiable systems level factors. And this is the continued global collaboration is essential for the progress, like CellNet is important for the community in sarcomas. And only for finish my presentation is like always, these meetings is possible to share sometimes with old friends and new friends. Thank you for the invitation.
Thank you very much. Thank you very much for your presentation, Dorian. So now we have the last 25 minutes to open questions and to discuss. I suggest we can start with Bruna, that she's involved in the year that was the chondrosarcoma. So questions are open to Bruna. If you want to raise your hand or to discuss. At the very beginning, Bruna, we have to know that the chondro was considered the sarcoma of the year, and that is a chemo-resistant tumor model, as we mentioned, and probably the trial that was present in the setting of the death receptor 5 agonists are the first really very planned randomized trial in this occasion. Which is your main consideration about the type of chondrosarcoma that was involved in the trial? It was classical. It was allowed other type of chondro, and you mentioned that was really the response of the response was not presented, but the time to progression of the PFS was included all patients with EDH mutated or non-mutated. So which is your main consideration at this point?
Yes, good question, Matthias. Thank you. Regarding the chondrosarcoma subtypes, they encompass just conventional chondrosarcomas in both trials. The Vasildenib trial and also the Zekbar trial. And it's a big question about these inclusion criteria because we are not included the differentiated patients. But there is some points that I want to highlight here. The first one of them is that IDH mutation was not a concern in the in BRICS 109, the ConDragon trial. So patients responded very well, regardless of the mutation status. And the second point is that when IDH was mutated, apparently patients were responding even better. So it's a very nice data to think about combining strategies. Both trials does not include high-grade the differentiated patients, but they include grade 3. There is a concern about the first event of, for instance, IDH mutation, which is know that's a very initial event. So we can have this event being lost all over the time if you have a patient metastatic after many years of diagnosis. So we can lose this pathway of inhibition, but for DR5, it's not a concern for activity, for instance. The entire cohort was very responsive, as I said, regardless of the mutation status. But again, we are talking about conventional chondrosarcomas.
Excellent, Bruna. Nadia?
Yeah, I just wanted to make a comment on this study. First is that the demonstration of progression was very exigent on baseline. This is important because sometimes some conventional chondrosarcomas could be quite indolent, and sometimes even follow-up is an option in selected patients. But in this study, the demonstration of progression have to be there in the 6 months precedent to the inclusion of the patient. So all patients entered in the study in resist progression, which is important. I think the data of this study is very encouraging because it's as you said, the first prospective randomized trial showing PFS advantages in chondrosarcoma, and potentially the first approved drug in this setting, which I think it's very important for our patients. And I just wanted to comment on that. Bruna said that there were some concerns on DR5 agonist regarding toxicity, especially liver toxicity. And I just wanted to share with you our experiences, because we had in our center one patient experienced this liver toxicity during the first cycle. So this is potentially very dangerous, but if you manage it, if you follow the patients carefully and you are very on the patient, especially on the first cycle, this can be very well managed. So this toxicity is usually in the form of grade 3-4 transaminitis, and the patient can even have problems with liver function, sorry. But it's important to monitor the patient during the first week of therapy, probably making a blood exam on day 5 to 8. If the transaminases do not elevate during this time, during the first cycle, it's very rare that they are going to do it in further cycles. But if you detect that transaminitis arise during this first week, you have to admit the patient and you have to start steroids and manage this toxicity in a quite aggressive way, because it's very, very, very rare. It's like 1% or less of the patients, but this has to be taken into account. But in our experience, even with grade 4 transaminitis, the patient, once the therapy was started, he evolutioned very, very well. And in all the other patients, we didn't see really any relevant adverse events, to be honest. So I just wanted to comment, to share with you this experience.
Thank you,
Many
Nadia.
plasmapheresis needed this patient exactly.
How many?
Yeah.
In this patient, we made 3 courses of plasmapheresis. The third one probably could have been skipped because the transaminases were already going down, but we made it for being super sure that the toxicity was controlled. The first plasmapheresis and the second already were able to diminish the transaminitis from grade 4 to grade 3, if I don't remember badly. And in addition to this, high dose corticosteroids were given, and also N-acetylcysteine as a liver protector. So this is the combo, let's say. But if you see grade 4 transaminitis, plasmapheresis could be even indicated. So not in all patients, but if you see a rapid increase achieving grade 4, plasmapheresis can be also useful and sometimes necessary.
I'm sorry, Nadia. I just reconnect because the line is very bad. But do you mean increased transaminase without bilirubin? Just
in our patient, we didn't see a high bilirubin elevation. It was just transaminitis.
I was just thinking about the indication of plasmapheresis. I just had the experience of methotrexate.
So
it's similar to the toxicity to methotrexate, or there is some differences we should be aware.
I think here is more lysis in terms of inflammation because of activation of TNF and apoptosis. So in this case, in our patient, we did plasmapheresis even in the absence of bilirubin elevation, because he achieved, if I don't recall badly, like more than 2,000 units of transaminases. So it was a grade 4, but in terms of toxic hepatitis. So we need
No, just because with methotrexate we observe very frequently, especially in younger kids, and it's usually rapidly transient. But of course, the experience with this is very limited. So, and also there are more older patients, so I think it's a good point.
So, Bruna, do you consider that with this trial, this different drug, this agonist is going to be approved in this setting, or do you believe that we need more data to support? Because we know that this is not an orphan disease, but we have less response with chemotherapy. We use to VEGF inhibitors. So do you think that this is the approval trial, or we need to prove more than?
Matthias, as Nadia just said, I think they are very encouraging data. We don't have previous data like that for a specific pathway in chondrosarcoma. So I don't know if that you can say that it's not an orphan disease. I guess that depending on the subtype, you can say that, especially for low-grade tumors. So they most of the time they just don't respond to conventional therapies that you have. So I think that's a very encouraging data to push for new approvals. Yes.
Thank you, Bruna. Let's go to Fernando's presentation. That was really an excellent presentation regarding immunotherapy in sarcomas, immunotherapy plus chemotherapy in sarcomas, the CONGRAT trial, the Javier trial. Then he presented some data with hemangioma epithelial and new ADC in this subset. Going back to the chemotherapy plus nivolumab. Fernando, do you think that with this data is almost 69% of rate response? It's like a lymphoma. So, and it's UPS, undifferentiated pleomorphic sarcoma. So, which is your main consideration with this data? I know that is a preliminary data with a phase 2 trial. And which is your concern with this almost 70% of rate response?
Matthias, I don't think that Fernando is online because
I'm back.
He's online. Yeah, he's online.
Sorry.
I am back.
Sorry, Fernando. The impact of this trial in our practice.
Yeah, we are. I think with this data, we really wanted to get the drugs to be approved for prescription already, because especially for the maintenance phase and prolonging the PFS for this patient, also the high response rate, which is very compelling data. So unfortunately, we don't have access to that, but for patients who are really symptomatic or has a disease which is not resectable, but it could be resectable with shrinkage. So this is the kind of protocol that really wanted to have access so we could prescribe for patients. Of course, I know we need randomized data to support our decisions here, but as you said, the numbers are really impressive, and yeah, I think that's it. Yeah.
Fernando, I just wanted to discuss on the histotype. Should we consider an all-comers approach in our future design, or selected histotypes, or even biomarker-driven?
I think for this specific histology, the UPS, the response with immunotherapy, they are not driven by biomarkers. So 70% of response rates and survival really interesting. I don't think we need biomarkers here. Of course, we will have at some point, but for practice, I don't think we need to put this in practice.
And going back to, and Javier and Nadia is here. So why the choice is just 1 year of nivolumab? Because if you consider other type of tumors, at least 2 years of pembro, 2 years of nivolumab. That is the common design of an immunotherapy clinical trial in terms of advanced disease. Why you select just 1 year, Javier?
It's absolutely arbitrary election. Is 1 year solar, no lunar calendar. I don't know if this is just because an arbitrary decision and waiting for the enhancement of the stimuli against the tumor. But for me, in UPS is clearly different than in leiomyosarcoma. Even in leiomyosarcoma, the combination of doxil, dacarbazine, and nivolumab achieved almost 60% of overall response rate. The truth is that in the maintenance phase, anti-PD-1 was not enough, and the majority of progressions took place in the early phase of the maintenance. On the contrary, in the UPS, the maintenance seems to be more active, more able to control the disease. I have to say that in both series, these cohorts exhibited a very aggressive behavior because the metastasis-free interval was extremely short. In the case of UPS, was less than 1 month, for instance. This is why this is a kind of selection, but selection towards worse prognosis, because in our country, typically the UPS is managed in localized disease with chemotherapy, perioperative chemotherapy. So these patients are not allowed to be enrolled in this kind of trials. And this is why we have selected those UPS that really were metastatic at baseline, or the metastasis-free interval was extremely short, and no perioperative chemotherapy was able to be prescribed. So this is the case for, despite this worst prognosis, at least theoretically, the response rate was very good, and we have learned that the maintenance phase should be improved in leiomyosarcoma, and maybe it's enough in UPS. This is the main conclusions. Obviously, the phase 3 is designed and approved by Abisco 2.5 years ago, but for some reasons, Abisco is not starting the trial. And we are now in conversations with Regeneron as well. And so we hopefully activate the phase 3 randomized trial, not only in these two specific histologies, but also in myxofibrosarcoma, in that differentiated liposarcoma as well, because there is some rationale to include this kind of tumors as well. And maybe also synovial sarcoma, because Chinese colleagues treated as well with chemoimmunotherapy synovial sarcoma with an apparent advantage. So this is the point. We are now in the private circuit for those patients with UPS. I'm explaining them about the results of this phase 1b trial. And some of them decided to start with the treatment. And so far, the latest 2 patients underwent this treatment, did very well and very good responses. So I think it's very, very active, and for me, is a disruptive finding in UPS at least, and I think also in leiomyosarcoma. It's different, but also it's important.
Thank you, Martin.
Uh,
Fernando, just
oh,
Manuela, go
sorry,
ahead.
I have another question for Javier in this context. We will discuss this morning on at Sylvester on immunotherapy and also in the differentiated sarcoma neoadjuvant approach. And I was thinking, given the data this year, to combine TKIs and immune checkpoint inhibitor in the neoadjuvant setting. How about adding to your trial the differentiated chondrosarcoma arm?
Yeah, I don't know. I don't know, but it's a good idea, I think, obviously. Yeah, definitely. Even if you are considering the combination of platin, doxo, and anti-PD-1 can be even more active because both drugs, doxo and platinum compounds, are able to induce the immunogenic cell death. So theoretically, can be synergistic in a superlative way. Yeah, so far we have the phase 2 trial with sunitinib and nivolumab with a good response rate in the differentiated chondro, 30%, roughly 30% of overall response rate. This is this specific phase 2 cohort is preparing the article, Sandra Strauss, and probably in the short time she will be able to submit for publication. And I think it's so far the best activity we have in the differentiated chondrosarcoma, but potentially can be overcome with the chemoimmunotherapy as well.
Okay,
Definitely.
yeah, thank you. But I'm really convinced because there is the anlotinib PD-1 trial published by Chinese in July, and it's a very similar design of immunosarc in the differentiated chondrosarcoma, and the objective response rate is 30% with a complete response in this kind of disease. I think it's something that bring us to the upfront setting, especially with the very, very bad results. My concern is actually the feasibility. It's an ultra rare condition. So I think it's important that if we decide a trial, we will do it together. Maybe I will mention this morning to the meeting, maybe that we discuss, and then we can, if we can find some collaboration for those difficult disease, rare condition. I think it's more.
Fernando, last and brief comment about, if you are still there, just a brief comment about TLS and fibronectin as drivers to treatment, because there are these are new drivers, because TLS that we have to establish with pathology, which is the real TLS that we can use as a biomarker, and the other is the fibronectin to drive into some new ADC. A brief comment to that.
Yeah, we are looking for TLS in our samples here when trying to prescribe immunotherapy for sarcoma patients. So we are really relying on the presence of TLS as the most reliable biomarker for the use of immunotherapy. But as I said, with this data coming from immunosarc, with the combination with chemotherapy, we would not probably use this approach. I mean, looking for TLS to prescribe, we'll probably just prescribe in combination. But at this time, we are in practice asking for the pathologist to report on the TLS, so we can maybe use immunotherapy for sarcoma patients. Yeah.
Okay. Nadia? because we are on time and we have two more speakers to discuss some
Yeah,
questions.
just it's a question for everyone, not just for Fernando. I was a bit disappointed on the results of Congrats study because it theoretically it makes sense to combine anti-PD-1 and anti-LAG3 drugs, but the results do not support at all that anti-LAG3 gives any advantage on nivolumab. Indeed, the results on the nivolumab monotherapy cohort seem to be better, even if not a fully comparative study. So I don't know if someone has a clue or a hint of why this is because usually Nivo-Ipi seems to be better than Nivo. TKI plus Nivo seems to be better than anti-PD-1 monotherapy. So the combinations that have been assessed in sarcomas with immunotherapy plus anything else seems to support that the combos do work better. But this is the exception. So I don't know if someone has any idea why. Is this because anti-LAG3 is a bad prognosis factor and the prognosis value is acting more importantly than the predictive value, or I don't know? What do you think?
Go ahead, Ali.
It's not so surprising, attending to the fact that in our immunosarc, for example, LAG3 was associated with better performance of nivolumab and sunitinib. Also, there was a poster on this CTOS that they showed the group of Susanna Strisovka in Czech Republic that LAG3 was also associated with better outcomes. And one of the hypotheses that they told us is that maybe LAG3 is trying to maintain some kind of homeostasis in the presence of T cells. It's true that this lacks validation, lacks testing, but it's not surprising attending to the data that we got, at least in the immunosarc trial, for me.
Okay, so it could be even detrimental to block LAG3 because LAG3 is helping the anti-PD-1 drug to act. Okay,
yeah, this is something that we need to test it. Why? Because it's not a mechanism that is described as far as I know, but
makes
sense. Be there.
Melanoma, you have example that is better in terms of progression survival, not in overall survival, and is quite better in right response in melanoma. So it's a mechanism of resistant expression of LAG3. So I guess that in melanoma is the only model that was approved in first line, but it's for patients that are probably not fit to ipilimumab. So it's less toxic, but is obviously less effective. So
I was about to have this positive melanoma, no? So maybe there's a different pathway of inhibition. They are crossing the paths, I don't know.
Okay. There is a question to David because we are on time, but which ATRX antibody clone was used in the study? David.
This was not explained by the author. In the presentation, I was trying now to recover it, and it was not there, so I cannot help you with that.
Okay, and in terms of the loss of ATRX, because it's very common in sarcoma, do you think that it's going to be really a biomarker or a driver to some treatment, or just a very common mutation in a rare group of tumors as sarcoma?
The data presented suggested that the TED inhibitors could be highly active on these tumors, and I think this is something that deserves attention. At least some clinical trials should abord this point. And it's true that, as far as I know, there is no ATRX inhibitors in the market, but EPO inhibitors could be helpful.
And you mentioned in the angiosarcoma microenvironment study that probably the TLS is correlated with something. Is real or is fiction?
Well, they did not evaluate TLS. This was one of the limitations of the study. I think it was also in the conclusions, but they evaluated CD20, and CD20 was good prognosis on this cohort. It's true that they did not separated head and neck from the others. I think it was something that they should have done, mostly because they were defending that the head and neck had more infiltrate, but they should analyze it. It's true that TLS, even in the study that Fernando showed, now the LAG3 PD-1, they were selected by TLS, but TLS still, I think, is still not perfect. Maybe there is some problems on the detection. Maybe we are not having the correct sample or analyzing the whole tumor, because we normally analyze one slide, one portion of the tumor. So I think there is a lot of things to do there on this area.
Okay, Nadia?
Yeah, with regards to the angiosarcoma and immunotherapy, let's remember that, for example, in the BOT-BAL study, botensilimab plus balstilimab, the overall response rate of visceral angiosarcomas was even higher than the scalp angiosarcoma. So this is just a message to say that even if it has been described that scalp angiosarcomas can be more responsive to immunotherapy, it doesn't mean that other angiosarcomas do not respond to immunotherapy. So considering the aggressiveness of the disease and the lack of other options, in my mind, every patient with advanced angiosarcoma should receive immunotherapy.
Yeah. This is one of the things that I showed, and I think it was, for me, it was surprising that they did not focus on that part, because they showed the S100 proteins that were correlated with head and neck, but they did not show or did not explain that markers of macrophages M2 Treg were overexpressed as well. So maybe because of that, these tumors, even if they are with a higher immunofiltration, the immunofiltration that is there is anti-tumor, have an anti-immunocheckpoint activity effect. So they need to check this data, because I think the data is good, but they need to go deep in on what they have.
Maybe those angiosarcomas with high macrophage infiltration could be, I don't know, more sensitive to TKIs, for example, or to other drugs. So there is a lot still to be understood in the immune environment of angiosarcomas. It's no doubt one histology very interesting for being immunomodulated.
Yeah.
And at this point, with the biomarkers that we have and with the information that we have, I don't think we can make assumptions of this is the angiosarcoma patient that is going to respond. So I think it makes sense to try in every patient with advanced disease.
David, regarding that, you mentioned that the B7 and H3 was the most important biological news that you have in the meeting, regarding that more than 80% of sarcoma patients have the validation of by immunohistochemistry. Is really validated, or we have to move more aggressive forward to trying to look at other issues?
Well, I think it's validated mostly because this is a big cohort. We are talking about more than 1,100 cases. And it is true that we need to get... Yeah, go ahead, Manuela.
Oh, no, I just wanted to add, and this, if it's validated, it can be predictive of response of something, because you demonstrated that it's not prognostic, but maybe it can be predictive to immune checkpoint.
Yeah, it can also, this needs to be evaluated. But in terms of validation of protein, it's true that we need to wait for the publication and see which method will be the adequate to evaluate this expression. It's true that we need also to understand if as Emmanuel says, that if, for example, in the Artemis, the expression of B7H3 could correlate with the activity of the antibody. So this is something we need to wait and see.
Thank you, David.
David, I was also thinking Artemis, but also maybe other immune modulator, because the expression is higher in all those immune very responding isotypes. So I wonder if there is a correlation. That was my I think. What's your opinion?
If B7H3 is a therapeutic target by itself.
Yeah, no, if it can be a predictor not only of the
okay,
target itself, but also yeah, immunotherapy, immune checkpoint inhibitor in general, because of the distribution that was clearly described by Khan on the study.
Attending to the fact that we are seeing almost 100% of cases with a higher expression, I have some doubts that we could identify or we could stratify patients, because we won't get negatives, we don't get low expression, mostly are high expression. So probably there is some limitations there, but something that we could check in some series, just for example in Immunosarc and others, to see if there is any correlation. But it could be
Or
difficult.
maybe a threshold that is not yet
It's
there.
a very high threshold could be, yeah.
Well, thank you, David.
Thank you.
Dorian, you mentioned that the STRAS 2 is with low recruitment. Which are the reasons, and if there is another STRAS 2 in Europe that is going to discuss this for retroperitoneal sarcoma are really in terms of groups, they are growing a lot. So which is the main reason to stop or to lower the recruitment in this phase, very important phase 3 trial?
It's a very important topic because I think it's the barriers for the approvals for each centers. For example, for approve in LATAM, it's very complicated because the Europe needs the approval for an university plus hospital plus local uh, is a local PIs and the local regionals, and it's necessary to make the different step types of the regulations. For example, I have around to 1 year, so try to include Mexico in the STRAS 2, and it's very complicated. I feel around to I don't know, maybe 25 emails and try to respond all the questions, and always appear new things, and I think it's the most important. This is the reason because the Strasbourg tried to solve this problem with a new policy for try to include more hospitals. I think it is the main problem.
Okay, Dorian. Javier, will you raise your hand?
Yes. So if I were allowed to write a letter to Santa Claus about studying the sign of in the retroperitoneum area, I would select leiomyosarcoma firstly in CellNet, because maybe it's not required more substantial skill, I can imagine, I guess. And maybe with the aim to explore the neoadjuvant chemotherapy with a combination of a kind of drug similar to trabectedin or lurbinectedin in combination with doxo and maybe anti-PD-1, or at least plus radiation therapy. This can be very, very interesting because I think the radiological assessment is easier in leiomyosarcoma. Maybe the surgery is not as complicated as the differentiated liposarcoma, and maybe we can obtain positive results because the rate of metastatic recurrence in the context of leiomyosarcoma is maybe higher than 50%. So maybe it's a good idea to try or to explore this kind of sequence. We are working in our lab with the next generation drugs which are derived from trabectedin, and I can't wait to know about the combination with radiation therapy, which is very high in the case of trabectedin and in the case of lurbinectedin, and maybe also with the new compounds. But can be a good idea and can be maybe be developed in the context of CELNET and some other countries. What do you think, Dorian, about the easier way to select patients in retroperitoneum area in our context?
I think it's necessary because the recurrence is very frequent in these patients. But the problem is how to design this study because in different countries there are different types. For example, the protocols for radiotherapy, the equipments are different and need to try to make a protocol with the homogenic characteristics for try to have good conclusions. This is
Yeah,
the
sure.
I think this is the first problem, and the second is how to identify what is the patient that responds very or better in the immunotherapy. The immunoclass is very interesting, but not in all the countries it's
Yeah.
possible to try to make the studies for this. I think this is the first barriers for this, but I think it's necessary for these patients.
Yeah. Yeah,
Thank you.
I was talking about the clinical trial design, and obviously this should be unique and homogeneous. And on the other side, radiation therapy in the context of leiomyosarcoma, according to STRAS, is not recommended. So, but within clinical trial, and if we are able to demonstrate the synergistic effect between these new compounds derived from trabectedin plus radiation therapy, this could be a good idea to take into account. And obviously, the response should be measured by MRI baseline versus third cycle, and also maybe by pathological response. But maybe this is a good idea in the context of our network. I don't know. David, do you have some timeline for which we can know about this combination and about these results with the new compound of derived from trabectedin?
We are just waiting for the data from PharmaMar. They are doing the cell cycle, the timing of where we pick the G2M. The only thing is that now, currently, they are saying that maybe it's not a G2, it's more a G1, so we have to do it ourselves also on our lab. But the idea is to combine it in January, hopefully, because the meeting will be in January. They will present the data and we'll start working on that. Normally, it's between 2 to 3 weeks for the experiment to do because we have to wait on more or less 15 days so the clones can grow. But I think in January we can have some preliminary data on this.
Okay.
Okay. Dorian, the last comment from Nadia and question is, we know that the criteria inclusion for the STRAS 3 is going to be the differentiated liposarcoma, but grade 1 or 2. So probably, as Nadia mentioned in the chat, is what happened with those patients with grade 3 in the pre-op biopsy. So
No.
probably it's going to be, we need a pathology to discuss this, but Marco is here. I guess
No.
that Marco is here also. But what happened in those patients with the biopsy in the pre-op is grade 3.
No, Matthias, my comment was more that in the STRAS 2,
Yeah.
you have to demonstrate grade 3 in the biopsy.
Yeah,
So
okay.
even if the mass is clearly the diff, maybe you have a huge tumor And the biopsy, even if you direct it to the most necrotic part or whatever, you are not able to demonstrate grade 3. And this can be a barrier to include the patients in the study. I think that might have been one of the maybe reasons for not being so quick in the recruitment, because this is a very selective population.
Okay.
This is
And it's very difficult in our media to discuss grade 3 in the differentiation liposarcoma. I guess but that is the main reason that we need a pathology to discuss grade 1, grade 3, grade 2, grade 3, because it's one of the criteria of inclusion in at least in the STRAT 3. So we exclude grade 3, which is the comment in the meeting, Dorian, about this.
Yes, this is the challenge because it's very possible to the biopsy is not taken the correct side, and it is the reason because in some occasion is not possible to have the necessary points for include this patient in the protocol. And there are other barriers. I think it's the other most important barriers, and this is other is it is the university study, and some countries don't have the drugs, or the other is the classification for the surgery, and this is other point because in this moment there are any consensus about the extension for the surgery, and this is a lack in the trust because we do not define very well what is the surgery adequate, because the some centers, for example, North America versus Europe, have some doubts about the extension for the surgery, for example. And I think it's very complex. This is this topic.
Well, I guess we're done. We have to appreciate really the participation. We have to really have and say thanks to Imbrix company that is support this excellent webinar, showing that we can do it with rare tumors and rare discussions. But really, we appreciate all of you, and Cellnet is open to everybody. Thank you a lot, Bruna. Thank you, Dorian. Thank you, David. And thank you, Fernando, for the excellent discussions, and for everybody. And please have a nice finish of the year here from Latin America. We are going to get into vacations in January, probably. So you are in Europe, you are in the middle of the year. So I guess that was a very nice opportunity to hear and to listen to everybody. So thank you a lot, and have a nice week and the rest of the year. So thank you.
Bye bye.
Joey, take care.
Bye.
Okay, bye.